dementia over talk. Sapna. Sapna Peter. Cannot talk as a Sapna. Sapna Jagdish का कंट्रोल करिए.
तो टॉक चाले છે
Actually mute करो.
Okay, so here we go. Yes, good morning, everybody. Welcome to this Saturday morning meeting. Today we have with us Dr. Sapna Patel Kuhl. She's Program Director, Internal Medicine Residency, Ascension St. Ignace Healthcare at Maryland, USA. And she has several honors and awards to her credit. She has held several administrative posts. Recently, she is member, Accreditation Council of Graduate Medical Education, Residency Review Committee for Internal Medicine at Chicago. She has been teaching medical students for several years and resident teaching also. And to her credit, she has several research publications and chapters in the books. She is going to talk about dementia, diagnosis and management. So welcome, Dr. Sapna. Thank you for joining us after 3 years. We look forward to your very informative talk. So over to you.
Okay, let me go ahead and share. Thank you for the invitation. I'm very happy to be here. And let me just make sure I get it
Yes.
there. Okay. All right. So I'm going to talk about diagnosis of dementia and management. I hope to make it practical and informative for everybody. My objectives are to really know the terminology and the common causes of dementia, to understand the types of clinical findings we find, outline some of the key steps that we go through in diagnosis, treatment options, whatever that are available, and then to understand the management and what it means to live, especially with Alzheimer's dementia, which will be mostly what I will focus on. So dementia is unfortunately one of the commonest challenges of aging. In the US, at least 10% of patients over age 65 are diagnosed with dementia. And over 32% of patients over the age of 85 will have some kind of cognitive impairment. And that could be anything from mild cognitive impairment to dementia. And currently, as you look in the US at least, over 7 million Americans live with dementia. And the sobering statistic, at least in the US, is that number is expected to almost will double by 2060. So lot of people will be living with dementia in the US and in other parts of the world as people live longer and are able to survive and surmount many cardiovascular challenges, only to succumb to some of these other challenges that we haven't found great treatments for. So simply starting, dementia is an acquired disorder. It is characterized by the decline in cognition. And it's not just the memory. Usually everybody thinks of memory as, dementia, it's their memory's going. No, it's actually, they do have trouble with forming memory, but there's also challenges with language. with executive functions, so organizing and planning things, ability to have complex attention, ability to use their motor skills. So doing more complex motor tasks become difficult, as well as social cognition and an ability to read the room, things like that over time. The most common cause is what is called Alzheimer's dementia, and that's the one that's seen in 60 to 80% of people. And many of these patients, because they're older, may also have at that time cerebrovascular disease, which leads me to the second most common cause, which is vascular dementia. And then there are some rarer ones, but still maybe more prevalent and not diagnosed, like dementia with Lewy bodies. And then there is something called frontotemporal dementia. And Parkinson's disease, which is common in older patients, can also have a dementia component. Not all patients with Parkinson's have it, but some do. And then there are multiple other causes of dementia, certainly multifactorial, progressive supranuclear palsy, where it predominantly affects speech and swallowing, corticobasilar degeneration, multisystem atrophy used to be called Scheidegger syndrome and would cause autonomic dysfunction and blood pressure drops when people stand up, Huntington disease, alcohol, trauma, like you have the wrestlers or boxers and American football players who get this often. And then even rarer is, of course, Creutzfeldt-Jakob disease, HIV, normal pressure hydrocephalus, which is often underdiagnosed and missed in older patients, and then B12 and folate deficiencies. So I'm going to focus mostly on Alzheimer's disease. And it is a disease was named by Dr. Alois Alzheimer. He's a German researcher and pathologist by training, and in the early 1900s, he came across a patient who had a lot of memory loss, language problems, and sort of unpredictable behavior, which was unusual. So after she passed away, he did an autopsy and he found that the brain had a thinner cortex than usual. And he also found these abnormal clumps of protein, which we now know are called amyloid plaques, and then bundles of fibers, which we know are neurofibrillary tangles or tau protein. So if you look in this image, on the one side on the left is the normal brain, and then on the right is the Alzheimer's brain, where you can see that the cerebral cortex is shrunk. The hippocampus, that little seahorse-like shape on the brain, which is responsible for mapping recent memories, is shrunk. And then there is across the brain these depositions of what is called amyloid and neurofibrillary tangles. So what are the risk factors? We were just talking, how do you avoid Alzheimer's? How do I avoid getting dementia? Well, the best is not to age, but that is not in our hands. Aging is part of life, but women tend to be more affected. Genetics, certainly there's a component, but it's not like an autosomal dominant or recessive inheritance. It's not a completely clear inheritance. So it's definitely some genetics may play a role, but there's a lot of lifestyle things that can affect it. So cardiovascular health is very important. No smoking, lack of physical activity, poor diet all contribute to increased risk for Alzheimer's. Traumatic brain injury, type 2 diabetes, recurrent bouts of untreated depression, and hearing loss. So people who have hearing loss but don't wear hearing aids are at much higher risk of developing dementia. So a simple thing that can be treated would reduce the risk of developing it. So what is essentially happening? The episodic memory that we put together every single day with the things we do, and that's mainly in that hippocampus and medial temporal lobe structures. that mapping of memory slowly goes away because those areas shrink. And then later on, your more complex memory on motor learning, so how to do certain activities, procedures, steps in a procedure, those are spared relatively early on. But then those can also be impaired. And then memory for facts and vocabulary and concepts also starts to get affected later. Other symptoms you can see, and this is what we call that silver lining of a dark cloud, is that as people lose their memory, they also do not realize they're losing it. So initially they may realize they're losing it, but then there is what's called anosognosia, which means that you don't know what you don't know. Basically, you don't remember that you're losing it. And so people underestimate the loss of memory, and they may even early on offer alibis, so they find ways to explain things on why they can't remember. There's visual or spatial impairments, so driving, things like that can be affected. Word finding difficulties, so not names. Names is something we all sometimes forget of people, but that's not necessarily it. It's more objects and things like that that they have difficulty with naming and remembering. And then behavioral changes, anything from just apathy where they don't want to engage, they don't talk, they don't participate in anything socially. They may even become irritable. There's agitation episodes, aggression. Wandering is another big problem. Sometimes people leave the house and forget where they are. Psychosis and hallucinations, delusions, where they may believe that the person that they care about is inhabited by someone else. That's a common delusion seen in Alzheimer's. And misidentification syndromes. Other symptoms are the learned tasks, motor tasks. So first, you may lose some of the complex multi-step activities. So remembering how to cook a certain dish, which has many steps, may be forgotten. Then it may be dressing, using utensils to eat, and other self-care tasks. Smell is often affected. Sleep is often affected. Seizures may occur in some patients. And some other atypical presentations are also possible. A lot of times patients come with anxiety. Oh, I'm getting old and I'm forgetting people's names, so I must have dementia. Let me know. So they often, there's a lot of anxiety around developing dementia. And if the patient is more concerned, but the family isn't, that's most likely not dementia. They're also able to remember when they've had an episode where they forgot something and then they later remembered it. So those are not people developing dementia. Everybody has occasional word finding difficulties, but their daily function is preserved. Clinical course of Alzheimer's typically is an 8 to 10 year average life expectancy, but the range is wide. It can be anything from 3 to 20 years. Depending on when people develop it. And so the big things are the cognition, their function, their behavior, and then some specific neurologic features which can be seen over this clinical course. Now, this is called the staging of dementia. It's also called the global deterioration stage or Reisberg stages. And the earliest stage is actually there's no cognitive decline. There may be just some subtle changes, but no evidence on any testing that you find. Early second stage is very mild dementia where you may have misplaced objects, you forget names, but you're able to do all your activities of daily living, you're able to work and do things. Third is mild cognitive decline where you have difficulty concentrating, difficulty with complex tasks, and there's some denial anxiety about the deficits. Then later on in 4, you would start forgetting personal history, handling finances. There may be a reduced expression of emotions, and People withdraw from situations that are challenging, so they purposely don't put themselves in those situations. And in the later stages, 5, 6, and 7 are significantly harder to hide or pretty obvious to people, where people may need more assistance. They may not be able to tell you where they are, the time, place. They may not even be able to choose what to wear, may need some help with activities of daily living. There may be some, and then when you go into 6 and 7, there are more bowel and continence issues, sleep disturbances, personality behavior changes, and then your ability to feed yourself, take care of yourself, are all diminished significantly. So this I thought was interesting. This is an artist. His name was William Udermolen, and these paintings are in the museum in London. And the first image, if you look on the top left, this one is a self-portrait done by the artist back in 1967. And then in 1996, the second image on the top is when he got the diagnosis of Alzheimer's. So every year he decided he would do a self-portrait. And you can see how from 96 to 97 to 98, 99, and 2000, you can see how his visual-spatial skills and his ability to do a self-portrait declined. And so he decided to chart this till he no longer could do it. So I'm going to go through dementia with a case, and I'm just going to give you a hypothetical case of a Mr. Desai who comes to you and is for evaluation. So it's a hypothetical case, but it's based on a case I've seen. It's a 78-year-old gentleman. He came in with a chief complaint of memory problems. His past medical history is of diabetes, hypertension, some gout, osteoarthritis, and he also has some heart failure with diastolic dysfunction. When you sit down with him, his wife actually starts talking first and says, I'm very worried. He's not eating much. He's also losing some weight, maybe making some mistakes when he takes his medicines. Sometimes he's more anxious and irritable than he has been before. He is still driving, but I'm not sure he should be. Patient says, I'm okay. I'm doing fine. I don't really need to be here. I don't know why she worries so much. So this is often the case where the patient themselves may not see a deficit, but their loved ones who see them every day start noticing deficits and are the first ones to bring the patient to the doctor saying there may be something wrong here. One of the common tests and memory tests we do is called SLUMS. It's St. Louis University Mental Status Exam. And when you do it on this patient, he had a score of 20 out of a total of 30. And I'll walk you through that in a bit. When you ask more history, and when you see patients where you suspect dementia, it's important to ask for family member concerns there. To also get a baseline of function, how high functioning is this individual? So how much of a decline there is. So it's different from every individual. So if they are actually working and holding a job, which is more professional work, and then they develop it, it may be difficult to tell apart. And what is a typical day like? What do they spend their day doing? And that's very important in helping us assess how much of a decline there may be. And then specifically, what types of problems have you noticed? One of the common things people will say is they repeat the questions. They ask a question, then they forget 2 minutes later, they ask the same question again. Or they repeat a story about something that happened and they tell that same story again and then again and again. They also make more lists because they recognize they need lists to remember things, and misplacing of objects can happen also. It's not often the date that they forget, but they don't remember what day of the week it is. So that's a curious thing too. And problems with conversations, complex conversations with stories that you have to follow may be difficult. They may have trouble finding words, but names of objects, like I said, they may even get lost. Things that they're very used to finding, they cannot find anymore. Driving in the neighborhood, in the city, they sometimes may also have visual problems, because remember, visual spatial is affected. So people will keep getting new glasses. Something's wrong with my eyes. Let me get my eyes checked. And it's actually a sign of dementia, and people keep thinking it's a visual thing. Difference, any changes in making decisions? Do they not make them anymore? Have they been victim of many scams? One of the problems in America we have had is that people do this telephone solicitations, and they call up older people who are lonely and start talking to them, and before they know it, they get their bank account number, and then they end up transferring or getting their money stolen from them before people can realize. And then when they realize, they're embarrassed, they may not tell anybody. So that's a common thing we see around people developing dementia, is that people figure it out and are able to steal money from them. Mood can change. They may be more moody, or they may just not care. There may be more severe challenges like falls, hallucinations, bladder issues, things like that. And the important thing is to look at the medication list. So when Mr. Desai came, you have to make sure that, is there any medicines that can affect his sensorium? Because many medications that we routinely take and give affect the brain function. And so remembering to remove those agents and see if there's really dementia, or is it an effect of those drugs. Commonly, we see like the urinary incontinence agents that are used, like oxybutynin in this country, scopolamine, antiemetics like prochlorperazine, promethazine, tramadol for pain. All these can affect patients' function of their mind. Meclizine for vertigo, things like that. Antipsychotics, antidepressants, digoxin, steroids are often given for a whole host of conditions, can affect the sensorium. Even things that are like antidiarrheal agents, muscle relaxants, of course, sedatives, of course. So the next thing you would do would be to do an exam, and then specifically you want to make sure there are no neurologic deficits on exam, which may lead you to a different type of dementia or a Parkinson's or another associated disease. So gait difficulties, eye movement changes, and then the testing of cognition, as we talked about. So what are those testing of cognition that we said? So there are many different tests, and you can Google these and find them. Mini Mental Status Exam, MMSE, is a 30-point scale, and we often do that. That has been studied the most, and it has pretty good sensitivity and specificity for dementia. But there's another one called MoCA. That's one we use more in the hospital. Mini Mental we use in outpatient more. MoCA is better for screening for even mild cognitive impairment, or MCI. And so mild changes in executive function can be picked up with a MoCA, or with the SLUMS, which I will share with you in a second. Mini cognitive is just giving them 3 words verbally, and then talking about other things, and then going back and asking if they remembered those 3 words. And a clock drawing test is very quick to do. Make them draw a clock and give them a time to draw on it specifically, and see how well they do. So here's an example of SLUMS, and let me make it bigger for you so you can see, but this is how it's like a 1-page form. And it can be like, what day of the week, what is the year, what state are we in? Please remember these 5 objects. A question about, like, here's $100, you go to the store, you buy a dozen apples for $3 and a tricycle for 20. How much money have you spent left? So simple things like that. How many animals can you name in 1 minute? Things like that can be helpful. Telling people a story and then asking them questions about that story. So immediate memory can be very useful for finding out. The other thing we look at is ADLs and IADLs. ADL stands for activities of daily living, like bathing, dressing, toileting, continence, transferring, and feeding. And these are the fundamental activities that people are usually independent in, but can be affected later on in the course of illness. But before those are affected, this is IADL, so the instrumental activities of daily living that can be affected, like their ability to use a smartphone or technology, shopping, food preparation, responsibility for your own medicines, as we noticed with the case of Mr. Desai, being able to handle finances. So if you go back to the case I brought of Mr. Desai, he had no problems in his basic activities of daily living. But when you looked at the instrumental activities, there were some issues with taking his medicines correctly, maybe not getting the right groceries when he goes out to buy something. Transportation, meaning being able to find his way in driving, it related issues. So he had a couple of issues in his IADLs when we're talking to the patient and family. And always when you have someone with dementia, you must rule out depression and anxiety. Depression can look like dementia. Depressed patients have no interest in activities and will withdraw, and so may, for all intents and purposes, can look early on like dementia. The lab test we routinely do when we see patients with suspected dementia is, of course, the usual blood counts, electrolytes, renal function, liver disease, but we also look for B12, folic acid deficiency, thyroid disease, and in certain cases, we may even test for syphilis or HIV. And we always screen for depression, as I just mentioned. Imaging is not necessary absolutely, but is often done in the US because you want to exclude any other forms of dementia, any tumor or any other like normal pressure hydrocephalus, which you can treat. So if you want to look for things that may be treatable otherwise and not diagnose them as Alzheimer's. So here's an example of an MRI where you can see that the hippocampus in both these images, both sagittal and coronal views, is shrunken in size. But there are age-based parameters, so they have to be carefully evaluated. There's also something called the amyloid PET, which is not paid for by most insurance companies in the US, so it's not done all the time, but there are centers that do it, and they look specifically for how much amyloid tracer is taken up by the brain. And that can be specific to Alzheimer's dementia, and so some people get this test done. Because there are now some treatments that can focus just on amyloid, and I'll talk about those later. When you see patients with dementia in office, we usually look for signs where it may not be Alzheimer's and we need to refer them to a specialist. So if they have it at young onset, there's a rapid progression in symptoms, or they have recurrent falls, so it may be a Parkinson's or another kind of multisystem atrophy or another kind of Parkinsonian-like syndrome. psychotic features, so there's a different type of dementia there, or some other atypical things or Parkinsonism. So somebody like Mr. Desai that you would see, you would then try to, at the end of the visit, try to discuss the diagnosis and make sure that you explain what that means and why you suspect it. It is something that is established over time as you see patients' symptoms and get the right story. You want to make sure that there's some education for the caregiver, that you may have to watch if they're responsible for finances, maybe somebody else has to take over, or some other activities have to be supervised more. There's also a lot of dementia care services in the US that you can give them information about to go to get resources and to get educated. If there are behavioral symptoms, there might be some management things that you may have to talk about. And ultimately, you may have to talk also about some priorities and preferences and how they may want to choose to live their life, knowing that they have this diagnosis. Certainly, driving is another thing that you would want to make sure that you counsel and make sure people don't drive if they're developing this kind of cognitive impairment. Medications, I want to spend a little time in medications and what treatments are there out there for it. We do know that in Alzheimer's dementia, there's a reduced cerebral content of choline acetyltransferase. And this leads to a decrease in acetylcholine synthesis and impaired cortical cholinergic function. And so the whole theory has always been, well, if we use acetylcholinesterase inhibitors, they may make a difference. And there has been a lot of hoopla about it in the US, certainly. And there are 3 drugs now available, donepezil, rivastigmine, and galantamine in the US. They're all 3 have indications for use in early Alzheimer's disease. Excuse me. Unfortunately, they don't make a huge difference. Excuse me. There's only some mild change in the scoring system. So if you look at the screening tests we talked about, maybe a couple point difference. And they often have a lot of GI side effects with nausea, stomach upset, and so they're not always well tolerated. Memantine is one that is what is called an NMDA receptor antagonist, and that is often used for moderate to severe Alzheimer's dementia. But again, very modest improvement in symptoms. Off-label drugs, a lot of them are routinely used, and the ones that we often end up using are atypical antipsychotics, which are often used for mood management, behavior management, anxiety, stress, and they are olanzapine at like a 2.5 milligram dose, small dose, and then you can up it, or selective serotonin receptor antagonists, or some of the antidepressant medications. Unfortunately, the drugs have not borne out and are not very useful. And some of the non-pharmacologic treatments are just making sure people have adequate cognitive stimulation, doing activities that utilize the brain, keeping themselves busy, both physically and mentally. And then a lot of effort has to be put to teach the caregiver about what to expect, because there's a lot of stress that comes on the caregiver to watch their loved one go through and decline. So we spend some time often talking about caregivers and also seeing how they're managing and what kind of goals they want to set with the loved ones and get the help they need. In the US, we also want to make sure that they avoid excessive ED visits. We often discuss what's called a MOLS, that's for Maryland, but if for anything, any part of the US, it's basically an advanced directive form. And what are their goals and what would they want to be treated for? How aggressively would they want to be treated? We assist with ordering of what's called durable medical equipment if they need anything for assisting them, and then spending some time on insurance coverage. I want to spend a minute here on these new treatments because a lot of people got very excited when they came out, but they are again not having borne out as much as we hoped. So as we talked about, Lois Alzheimer's about over 100 years ago found amyloid plaques. And so they finally found some antibodies that you could direct against this amyloid beta protein in the brain. And two of these are approved in the US, lecanemab and donanemab. And they're not available all places. They have to be administered at specialized centers where they can monitor patients closely who are getting these treatments. And the people who are eligible for it are people who have had those amyloid PET scans. They have amyloid that has been found in the brain, and then they go for these specialized treatments. And they usually are people early on in the course of their dementia. And the potential of benefit is that it can slow the progression by about 25 to 30%. An important caveat is it does not improve cognition or function. All it can do at best is slow down the progression. And they have major side effects. So everything from infusion reactions, because they're intravenous drugs, and then they have what's called ARIA, or amyloid-related imaging abnormalities that can be found. And so these drugs cause focal vasogenic edema in parts of the brain. And so some people get headaches, confusion, dizziness, vision changes, and you can even get bleeding in parts of the brain. So they need to be closely monitored. So they are again used in specialized settings. Some are given once monthly, one of them is given once monthly, one is given twice monthly. But it seems like amyloid, as we understand dementia more, seems to be an end result of whatever process is going on in the brain. And so it's like trying to tackle the result of something, but not understanding the process, the primary process, and nipping that in the bud. So we are not there with dementia where we can really understand the early changes and what's bringing those about. Why is the brain having these deposits? We still don't quite understand that. Just want to briefly talk about what to expect in moderate and advanced dementia and what we would do for patients in those. In moderate dementia, things like walking home, paying bills, cooking, using the bathroom become more difficult. People forget how to do it. Memory loss is much more significant. The ability to sit and read and focus goes away. You may have hallucinations, more depression, and appetite is lost. So there's no desire to eat, and you have to remind people to eat or feed them if needed. And then as dementia advances, you have much more profound memory deficits where people may recognize a face but not even remember their loved ones' names. And then eventually they may not even recognize any family members. Speech becomes very limited, just a few words. and they're total functionally dependent on someone else to do everything for them, from brushing their teeth, helping them in the bathroom. They may not walk anymore. They may not do anything at all for themselves. And this last stage of dementia can last for some time, and it's very disabling for patients. So here's a study that went through and looked at cases of advanced dementia in a nursing home. And over an 18-month period, what they found is out of the 323 people who had advanced dementia, 55% of that cohort passed away. And the median survival was around 1.5 years in the advanced state. Infections and eating problems were the common complications. So recurrent infections, everything from UTI, pneumonia, they keep happening again and again and again. And adjusted 6-month mortality rates after development of pneumonia was 47%, a febrile episode 45%, eating problems 39%. So very high 6-month mortality because of the advanced state the patient is in. Other things like hip fractures, MIs, those were pretty rare in the last 3 months of life. So the big thing to do is to really try to plan as best as you can for a loved one with Alzheimer's dementia. It is making sure people know what to expect at the end stage, making sure that discussions are held with the person before they lose their memory on what would they like done, how would they like to be treated. Many people don't want to be kept alive or put on a ventilator in their end of life. Just let me go, don't treat those infections. It's okay when it's my time, let me go. So a lot of times that's things that can be written out, and we do advanced directives, and also making sure that you have the right person making the decision. So if it's not the partner, say the partner passes away before the patient, who would make those decisions? Making sure that you have healthcare proxies. And then hospice and palliative care can be very supportive and helpful for patients and families. Sometimes as dementia advances, you may have to alter the texture of foods, offer finger foods, smaller portions. Oral feeding is always, always preferred over tube feeding. So we do sometimes end up putting tubes in the US in patients, but really does not prolong life. And patients still aspirate with tube feeds just as they do when they're eating. Often we discontinue chronic daily meds that may be preventing diseases like heart disease, things like that over time, because the less medicines that you have to convince a patient to take, the easier it can be to take care of them. Ultimately, with dementia, this is a disease that affects anybody, and it's very difficult to predict who will get this. And over time, people have talked about it, but many times in many cultures, people don't talk about dementia or discuss it amongst family and friends. So it's sort of something that should be talked about more, because I think it would help people feel more comfortable and be able to get the help that they need. I just wanted to share some pictures of famous people who have come out with dementia. So Bruce Willis, he had frontotemporal dementia, is a famous actor in the US, and Robin Williams developed Lewy body dementia. Margaret Thatcher, Ronald Reagan, even Scotty, the guy on Star Trek, has developed dementia. And then I think Ranbir Kapoor, I was looking for in India, who had come out or been found to have dementia. So many people, unfortunately, suffer the consequences of this disease. So I just wanted to conclude by talking about how there are a group of progressive brain disorders that slowly destroy memory, thinking, reasoning skills, and eventually impair the ability to perform daily tasks. Alzheimer's, we know, is characterized by these classic amyloid plaques and tau tangles that disrupt nerve cell function and cause the brain to shrink. The exact cause is not well understood, and there is no cure. Medications may help some with symptoms, but with progression, there is very little improvement that we see. And supportive care is key, focusing on safety of patients, daily living assistance, and managing behavioral challenges in these patients. And while no one can change the outcome of dementia or Alzheimer's, with the right support, you can change the journey. From Tara Reeds. I thank you for your attention, and I'm happy to answer any questions.
Thank you, Dr. Sapna. You may stop the screen sharing, present.
Okay.
Yeah. So wonderful. I mean, you simplified the whole thing in a very comprehensive manner. And we non-physicians and non-neurological people also could understand what exactly is going on. Pretty, I mean, worrisome disease, because I wonder what happens to their thinking. I mean, when they suffer from dementia, Alzheimer particularly, they cannot express themselves, or are they able to?
So early on, people may realize in the early stages of dementia that they are having difficulties with their memory. And they may mention that they're having difficulties and they're worried, but then they develop that anosognosia that I talked about, where they are not able to eventually remember that they are having problems with the memory. So they cannot remember that they cannot remember, if that makes sense. So in some ways, early on, they may feel it, but then later they go to a stage where they don't remember that they don't remember. So in some ways, it's blissful, because early on, they may be very stressed about it. But later, as the disease progresses, they cannot be stressed because they cannot remember to be stressed even, if that makes sense.
Is there any system whereby one can make a preemptive will that please do not treat me if I get Alzheimer?
Yes, yes. So we have very simple to complex forms that you can download from the internet. They're called advanced directives or living will. And we make it very clear, what are your wishes? What would you like done or not done? And it can be one page even, and just discuss it with a family member. And in the US, if you witness it, have a witness and you write it out, it's official. You don't need a lawyer or anything. And when they show us that document, then we don't do aggressive things. We respect what the patient's wish was. Because sometimes you'll see children will come in and the children want things done. Because they have guilt, they may not know what to do in a situation, they may be scared. They'll say, put him on the ventilator, do everything, do everything. Whereas the patient would have never wanted to be kept alive on a machine. So one of the things we often talk to patients and families is, at some point we are doing things to you, but not for you. So we are doing things to you, but we are not doing it for you. Because all I'm doing is prolonging the survival of the body, not the person. And at that point, what are we really doing? And for whose need are we satisfying? And would you want to be a burden? Because nobody wants to really feel like they were a burden to their family. And sometimes the cost of care can be very high in the US. Taking care of people and going nursing homes or having help at home is very, very expensive.
Mhm.
And so people go into debt trying to take care of their mother or grandfather or grandmother, and thousands of dollars of debt that they have because of that. Whereas the loved one would have never wanted to leave that legacy for their children.
You talked about financial scams also. So we in India, almost every
Yeah.
day in the newspaper, we read about digital arrest of elderly people having transferred lakhs and even crores of rupees to the
Yeah.
scamster.
Yeah.
Now I realize that the reason behind that is probably their dementia, which is making them vulnerable to the scams.
And mild cognitive impairment, which is common, very common as you age. And you may not even realize it. Plus, you're lonely. And now somebody is sweet talking you and taking so much time and learning about you. They may see you on social media. They may have things to connect with you. And so they can easily then scam people who would never have been scammed before in their life, but can fall for this kind of things because of the way people know you can get it from. So it's a real problem in the US, and I hear it's a real problem there too.
Yes.
Yeah.
The celebrities that you showed, no, probably they didn't have Alzheimer, right? They had some other cause for dementia. That's why they came out of it.
No, none of them came out of it. So
Okay.
actually, only two of them had a different type. Bruce Willis, who had frontotemporal dementia,
Hmm.
and Robin Williams, the guy who did Aladdin's voice and in the cartoon and did a lot of, he was a very funny guy, actor. He had he had dementia of Lewy body, and he actually committed suicide when he got the diagnosis. So
There is a question from Dr. Jagdish Chinappa. Any use of herbal supplements like ashwagandha?
yeah, I mean, there's not a lot of data on ashwagandha. People have tried vitamin E, they have tried ginseng, things like that, but there is no data. Ultimately, people are selling all these things, and ashwagandha has become really popular in the US right now. Everybody is trying to take, first, they were after turmeric. People were putting turmeric and eating so much turmeric that they were getting liver failure
I got
because too much turmeric causes liver failure.
it.
You're not meant to eat like big gobs of turmeric. And so in America, we don't do things halfway. Sometimes we do it all the way.
Last size.
But
So,
no, I
any other
haven't seen
questions or comments?
anything.
Yeah.
Yeah.
Any other questions or comments from the audience?
Various games and exercises are advised. Do they help anyway?
Yeah, I think they do help. Doing activities that engage your brain. But long-term data is not there yet because you don't have good randomized control trials. Ultimately, we have correlation, but not causation. So, we have studies where people who are more into you doing games, those puzzles, they tend to read more. They're less likely to develop dementia. But is it because they never had a tendency and they were also very cognitively involved in other ways? So they're not well controlled studies, so we don't know for sure. But it cannot hurt, so it is encouraged. So in America, people are always doing these Sudoku or crossword puzzles, things like that, to keep the brain engaged. Because I think the big thing we know is that when you lose social activity, you lose the work. environment, you lose that purpose. Sometimes that can affect people. And yes, I saw that that Jagdish Janapa wrote Patch Adams. Yes, that's exactly right. The guy who played Patch Adams, Robin Williams. Yeah. And body mass index, is that correlated with cognitive decline? It's not body mass index, but it is cardiovascular disease and diabetes. So it's not purely body mass index. We do know that there is healthy overweight also. So not everybody who is overweight will develop dementia. It's the people who have the diabetes with it or the cardiovascular disease.
Earlier, we used to hear the word senile dementia. I mean, where does that entity stand now in this umbrella term of dementia?
So nobody uses senile dementia now.
Okay.
I think mostly what was called senile dementia was probably a whole bunch of these things.
Okay.
And it was probably most likely the most number one and number two are Alzheimer's and vascular dementia. And so mini strokes. So a lot of people who have high blood pressure for many years that's not well controlled start having little mini strokes. And so we call them watershed infarcts in the brain, in the areas where the vessels are thinned out and they're very, very small. You don't have the big vessels there. In those parts of the brain, they get ischemia, and it's silent ischemia, and so little parts of the brain die. And so over time, they have the same kind of brain atrophy that you would see in dementia. Just the reason they have the shrinkage of the brain is because of a vascular pathology.
So there are diagnostic imaging tests whereby we can define these as vascular and not Alzheimer.
No, not any specific things. So MRI scans, some of them will have characteristic appearances. So if you have a classic appearance for hypertensive CNS disease, where you have more infarcts in the watershed areas, then good neuroradiologists will be able to pick up and say this is more likely vascular dementia.
Do they have better prognosis than Alzheimer?
No, they don't. The only thing is they may do better because you can keep the blood pressure well controlled. But what happens over time is these are the people who have developed stiffer blood vessels because they've had high blood pressure for so long. So the vasculopathy has occurred. And so the vessels are not the same. And so if you lower the blood pressure too much, then there's not enough perfusion of the older brain.
Mm-hmm.
So you have to keep it in a very sweet spot between not too low and not too high. That Goldilocks of blood pressure. And that is very hard to do. As we all know, we are always fluctuating. And it's hard to keep it in that range.
These days, guidelines are also changing. Recently, we had a talk by Dr. Rumin Shah where he said, now there is nothing like normal blood pressure.
Yes, we have gone lower, but at this point there is a wide range. We realize that there are some people who sit at 90 systolic, and that is normal for them. For them, 140 is too high. And we are realizing that people who are sitting at 140, for whom 180, 190, and over that will be high. So we are not all made alike for sure, and we want to simplify things when possible, but we are very complex.
Yeah, any other questions or comments? I think there is none. So thank you very much, Dr. Sapna. And we would expect you to visit us more frequently than at the gap of 3 years.
Okay. All right. Well, thank you so much. Thank you, Dr. Pandya.
Thanks.
All right.
So, see you all next Saturday. We will have Dr. Darshana talking to us on something about, she talks always about motivational topics. So I'll share the topic in a short while. Thank you so much for joining. We meet again next Saturday morning.
Thank you, Sapna, for the nice and informative talk. And thank you, Satish Bhai, for hosting us.
Thank you,
Thank
Mayur bhai, for
you.
joining.
Thank you.